We are running late. So, good morning to all of you. I welcome you in Oculoplasty IC. That is newer techniques in oculoplasty you don't want to miss. In this course, we are going to discuss newer techniques, recent advances in the management of the thyroid eye disease, retinoblastoma, eyelid malignancies, and new surgery in orbit and ptosis. We are having a team of eminent oculoplastic surgeons of international repute. They will discuss through a short video, short lecture, images of difficult and challenging cases. I hope after completion of this course, attendee will able to manage their difficult cases in easy and efficient manner. I welcome you all. First talk I am going to deliver, that is recent advances in multimodal therapy for eyelid malignancy. I have no financial disclosure. Written informed consent for use of photographs and investigation reports obtained from all patients. Eyelid malignancy may lead to loss of vision and life as well. Often lethal eyelid malignancies are diagnosed late in developing countries in our country. Survival is inversely related to the stage of the tumor at presentation. The eyelid carcinoma are basal cell carcinoma, squamous cell carcinoma, meibomian gland carcinoma, cutaneous melanoma, and rare one is the Merkel cell carcinoma, sweet gland adenocarcinoma, and metastasis to the eyelid. Basal cell carcinoma is the most frequent eyelid malignancy in Western white population. Tumor is of low-grade malignancy, is locally aggressive. Recurrence may occur after excision, but metastasis is extremely rare. Actinic radiation plays important role in pathogenesis of basal cell carcinoma. It primarily involves the lower eyelid and medial canthus. 50 to 80% of BCC are nodular and ulceronodular type. 5-year cure rate reported with margin control surgery is 98%. Squamous cell carcinoma is the second most common eyelid malignancy. Ultraviolet B radiation is the major risk factor. There is a distinct male predominance. Tumor is highly aggressive. There is a tendency of perineural invasion. Metastatic spread occur about in 10% cases and overall mortality 1.6 to 6%. The sebaceous gland carcinoma is a rare, although in Western country, but commonest eyelid malignancy in Asia constitute about 50 to 60% of all eyelid malignancies. This is most aggressive and lethal eyelid malignancy, relatively slow growing and mimics benign lesion resulting into misdiagnosis. Its multicentric origin and intraepithelial spread is one of the reason of recurrence. Sebaceous gland carcinoma predominantly seen in females, and there is a predilection for upper eyelid, lymph node metastasis seen, high recurrence rate, and overall mortality rate is up to 10%. The pathogenesis of eyelid malignancy, the squamous cell carcinoma, chronic UVA exposure involve the proto-oncogene and suppressor genes. The mutation of RAS oncogene seen in 50% cases and CKD-N2A gene 24%, which encodes the P16 tumor suppressor protein. Sebaceous gland carcinoma mutation is seen in P53 gene, and mutation also involves the DNA mismatch repair gene, which encodes the MMR protein that is responsible for elimination of errors during DNA replication. When you see the pathogenesis of the BCC, the sonic hedgehog pathway involved. Here is the patch gene and smoothen gene, and patch gene receptor bind site for the sonic hedgehog ligands. When it binds, it causes activation of smoothen gene, resulting into release of certain cytokines and vasogenic factors which cause cellular proliferation. The accurate diagnosis of eyelid malignancy is very important to decide the correct therapy. One must examine the type of the lesion, whether it is benign or malignant. If there is a loss of eyelashes, loss of normal lid architecture, and if there is a changing pattern of growth, size, then it is maybe malignant. Also look for the site, location, and its extent. And palpate the regional lymph node if there is a involvement. Then the radio imaging, that is CT scan, MRI, even PET, helps to detect the degree of extension, depth, and bony or cartilage involvement. For diagnosis, the histopathological examination, that is type of tumor and its differentiation, is very important. Excisional biopsy, that is diagnostic and therapeutic both. If the tumor is small size, the complete excision with 0.5 to 2 centimeter margin is good. And incisional biopsy, that is diagnostic, if the tumor is too large or deeply infiltrating, and if the lymph node is involved, then one should go for the fine needle aspiration cytology. The immunohistochemistry to look the biomarkers is again very important. That is, vimentin is a biomarker in eyelid sebaceous gland carcinoma associated with the epithelial mesenchymal transition. Vimentin overexpression in sebaceous gland carcinoma considered as novel predictor for lymph node metastasis and poor survival. Similarly, other stem cell markers like LDH1 and CD133, ABCG2, these are associated with poor prognosis in eyelid malignancies. If the lymph node tumor is more than 20 millimeter size, or recurrent tumor are more than 5 millimeter thickness, and in histopathology, if we see the intramural perineural invasion, sentinel lymph node biopsy must be done. Always go for the staging, that is TNM staging, that is a mapping out of the extent of tumor, which also helps in determining the prognosis and survival, and to decide the optimal therapeutic management. According to the TNM staging, tumor may be locally advanced or local tumor or systemic. Then we can choose the treatment modalities. There are various multimodal treatments are available for eyelid cancer, like surgery, chemotherapy, radiotherapy, cryotherapy, laser therapy, and topical therapies. If the tumor is localized, T1, N0, M0, one can go for the surgery. And if locally advanced and surgery is possible, then one can do the adjuvant chemotherapy and excise in toto. If surgery is not possible, then first go the neoadjuvant chemotherapy. And if the lymph node metastasis, then simultaneously in block excision and radical neck dissection can be done. In case of metastatic cancer, only palliative chemotherapy or radiotherapy can be given. Surgery is the gold standard treatment and only curative therapy. Determinant of successful surgical therapy are absence of local infiltration and distant metastasis. Microscopic invasion necessitates the frozen section biopsy, and sampling or resection of lymph node is important if there is a lymph node metastasis. Goals for surgical excision is complete histologically margin control, tumor excision is important, and to restore the anatomical integrity to provide the best cosmesis after excision. Principle is to reconstruct the anterior lamina and posterior lamina together, preferably at least one lamina with intact vascular supply. Other lamina can be free graft. The selection of appropriate technique of reconstruction is very important. It depends on the size of the defect, vertical and horizontal, location of the defect, whether tumor is located medial canthus, lateral canthus, and lid margin is involved or not. Age of the patient, tissue availability, and what patient wants, and it also depends on the expertization of oncologist. If the defect is up to 30%, one can do the direct closure. If defect is 30 to 50%, direct closure with cantholysis and canthotomy can be done. And if it is more than 50%, up to 75, tangent rotational flap and a U-gaze procedure can be done. If defect is larger size, more than 90% or subtotal, then Cutler-Beer procedure can be done. Here is a case of basal cell carcinoma, left upper eyelid in a young female, completely excised and well reconstructed by Cutler-Beer procedure last 5 years. She is asymptomatic. And another case of recurrent basal cell carcinoma operated thrice in other center was operated by reverse Cutler-Beer technique. Again, sebaceous gland carcinoma of the left upper eyelid, lower eyelid sebaceous gland carcinoma reconstructed by Cutler-Beer technique. This is a case of lower eyelid sebaceous gland carcinoma involving temporal half, that is temporal rotational flap was done. Another case of basal cell carcinoma, right eye involving medial cancer, that is most bad prognosis case, treated by mustardy cheek rotational flap without any recurrence for last 3 years. Then sebaceous gland carcinoma of right lower eyelid, again managed by mustardy cheek rotational flap. Then second option is the chemotherapy. If surgery is contraindicated due to poor general condition of the patient, or patient refuses the surgery, or extensive surgery leading to disfigurement and functional loss, then we can go for the chemotherapy. That is an anti-neoplastic drug which kills the tumor cell by interfering with the cellular function and replication of the cell. The chemotherapy may be 3 types. Primary chemotherapy, that is used as a sole anti-cancer drug. It may be curative or palliative. Adjuvant chemotherapy, that is given after surgery to mop up the microscopic residual. Neoadjuvant chemotherapy, that is given before surgery or radiotherapy. The neoadjuvant chemotherapy, it debulks the tumor to alleviate the surgical damage, to eradicate the micrometastasis after surgery, and leading to improved disease-free survival. The chemotherapeutic agent may be cell cycle specific like antimetabolite 5-FU methotrexate, cell cycle non-specific like alkylating agent like example cisplatinum, and they may be combination action. How to choose the anti-cancer drug, whether single drug regime or combination? Single drug regime, it kills a small fraction of the tumor only, while combination drug kill larger fraction of the tumor. The response rate is low in single drug regime, complete remission is infrequent, and there is a chances of drug resistance with single drug regime. While combination drug regime, the complete remission is possible, but there may be a chances of high toxicity. Before choosing the combination drug, 3 things one must consider. Avoid the drug with similar toxicity, choose the drug with different mechanism of action, and use maximum therapeutic dose of the chemotherapeutic drug. Before starting the chemotherapy, pre-chemotherapeutic evaluation is important to establish the diagnosis and to look the fitness of the patient. The comorbidity of patient, performance status, and physical examination, and body surface area must be evaluated to calculate the dose. And baseline blood investigation like hemoglobin should be more than 10 mg/cent, total blood count should be 4,000 above, platelet at least 1 lakh millimeter cube, and blood urea should be less than 20, serum creatine again less than 1.5. The counseling is very important before starting chemotherapy. Explain about the disease in a simple term to the patient, and extent of tumor, what was the plan and side effect of the treatment, and explain the prognosis. Give accurate answer of the question to the patient, and involve the professional counselor if necessary, because most of the cancer patients are psychologically compromised. Aim of the therapy is clearly whether it is curative or you are going to only palliate the patient. Informed written consent should be taken. Dose of the drug, chemotherapy, it should be standard dose, but can be adjusted according to the patient's performance and nutritional status, and even during chemotherapy, any renal function derangement. Always choose the drug schedule according to cyclic manner, because it give the prevent the drug resistance, give normal cell time to recover the drug side effect, and number of cycle based on the type and stage of the carcinoma at side effect. We are using cisplatin and 5-fluorouracil schedule for the basal cell carcinoma, sebaceous gland carcinoma of the eyelid. Cisplatin, that is 75 mg/m² on day 1, and 5-fluorouracil, that is 750 mg/m² on from day 1 to 5. And these are given every 4 weeks of interval. At least 3 to 4 cycle is sufficient. Then pre-chemotherapeutic drugs are important, that is IV fluid. So patient well hydrated to prevent the tumor lysis. Antiemetic should be given, particularly if you are giving cisplatin, that is a nephrotoxic drug, so diuretics should be given. Always evaluate the response of chemotherapy according to WHO criteria, whether the tumor is complete response, that is disappearance of all tumor up to 4 week, more than 4 week partial response if there is a reduction of more than 50%. And if there is no response, means less than 50% reduction in tumor size or increasing the tumor size. And also evaluate the drug toxicity, and we can take the histopathology pre-chemotherapy and post-chemotherapy. Here is the patient with histopathology were taken after chemotherapy. This is sebaceous gland carcinoma, neoadjuvant chemotherapy and reconstructed, and the large tumor which was given a neoadjuvant chemotherapy followed by radical neck dissection and simultaneously with the lead reconstruction by Cutler-Weir technique. The drug toxicity, the common myelosuppression, GI toxicity, hepatotoxicity, and alopecia. There may be specific toxicity, as I told, that cisplatin can cause nephrotoxicity and ototoxicity. Then comes to the radiation therapy. The external beam radiotherapy by electron radiation or kilovolt photon radiation can be given for the larger tumor. And the side, it is associated again with the side effects. It can cause hyperpigmentation, ectropion, entropion, xerophthalmia, radiation keratopathy, and cataract. The interstitial brachytherapy we are giving for last 3 years, the targeted radiotherapy, that is a minimally invasive radiation technique where we implant the iridium wire, that is through 2 to 3 wires parallel between 7 to 9 millimeter apart, which gives the 50 to 70 gray radiation. And indication is the tumor is less than 3.5 centimeter, absence of node metastasis, and we can give also it post-chemotherapy. Here is another patient having large sebaceous gland carcinoma involving the orbit. After 3-4 cycles of neoadjuvant chemotherapy, external beam radiotherapy was given. And the non-resectable tumor where only palliative chemotherapy followed by external beam radiotherapy was given. This was another extensive case of the squamous cell carcinoma complicated by orbital meiosis. I removed all maggots with mechanical debridement with using turpentine and chloroform, and later on 3 cycles of chemotherapy, and then external beam radiotherapy was given. Patient is planned for the spectacle mount. Alternative therapies are also available like hedgehog sonic pathway inhibitor, immune checkpoint inhibitor, immune response modifier, cryotherapy. The hedgehog sonic, that is vismodegib, and that is a newer drug but very costly drug. And imiquimod, that is again agonist of toll-free receptor, can be given to applied topically. This was a basal cell carcinoma complicated by orbital meiosis. After mechanical remover, I used the imiquimod and then excise this. Another case of extensive BCC. But imiquimod is a local toxic drug. It can cause conjunctivitis, keratitis, lacrimal, and ectropion, diminution of vision. So finally, I conclude that eyelid malignancy is a quite common morbidity, and its management is challenging in our country. Early and accurate diagnosis and appropriate treatment is mandatory. Surgery is the gold standard and only curative treatment. Complete surgical excision with tumor-free margin with appropriate lid reconstruction have been advocated. And neoadjuvant chemotherapy reduces the tumor bulk, allowing less extensive surgery, and hence advised for the advanced stage. Thank you. Thank you. Now, our next speaker is Dr. Achay Nair. He is a diplomat of the National Board from Chennai, Sankar Netralaya, and he is a fellow in Oculoplasty surgery from LBPI, Hyderabad. Dr. Achay Nair is a ICO fellowship of ocular surgery, oculoplastic surgery from New York, and his area of interest is the eyelid and ocular surface tumor, periocular aesthetic, endoscopic lacrimal surgery, and he has received so many awards, including APAO Achievement Award, Young Ophthalmologist Award, American Academy Award. Now, Dr.
Thank you so much, sir. So my talk is literally going to be just on this. What is an update on IgG4 related orbital disease? So first thing is, what is IgG4 related disease? We keep hearing this a lot, IgG4, what is it exactly? So the definition of IgG4 related disease is that any inflammation which on histopathology shows sclerosis, which is obliterative phlebitis. That means the blood vessels have inflammation leading to obliteration of it, with dense plasma cells around it, which stain positive for IgG4, which is a type of immunoglobulin. Now, these are the local histopathological features. Additionally, when you test the patient for systemic levels of serum IgG4, it is elevated. Only when these conditions are fulfilled can you call that the patient has IgG4 related orbital disease. But what is this? Why did it come up? And how is this different from what we already always treat as NSOID or IOID? So NSOID, the NS in non-specific orbital inflammatory disease is non-specific when the cause is not known. The other acronym that is used for this is IOID, which is idiopathic orbital inflammatory disease, which is just a fancy word for saying I don't know what it is. Idiopathic is also without a cause. But IgG4 related orbital disease is a new entity. So in 2008, a group from Japan found that they had patients with autoimmune pancreatitis. On biopsy, it showed sclerosis with plasmacytic infiltration. Along with that, serum levels of IgG4 were elevated. And they, of course, then later on with longitudinal studies concluded that IgG4 is an inflammatory marker associated with multisystemic inflammatory disorder changes. So, therefore, they have proposed to use IgG4 as a marker to diagnose and reclassify disease that was previously called idiopathic. So, IgG4 is not a subset of idiopathic orbital inflammation. IgG4 is not a subset of NSOID. If you are diagnosing as IgG4, then it is not idiopathic or non-specific. It then gets classified as a separate disease. What we know about NSOID or orbital inflammation in general is an open-ended non-diagnosis where inflammation is seen, response to steroids is seen, which always is not a diagnostic criteria. And many conditions can present as orbital inflammation. We need to rule out what is the diagnosis and try to get to a cause of it. Only when we don't find a cause do we label it as non-specific or idiopathic. Now, orbital inflammatory disease can either present as involving the lacrimal gland, which is dacryoadenitis. It can be myositis involving the extraocular muscles, or it can be diffuse orbital inflammation involving the entire orbit and orbital structures. Typically, it is acute or subacute with pain, unilateral involvement, diplopia, and symptoms that are pretty debilitating for the patient. What is our usual treatment plan for NSOID as we know it? We start the patients on systemic corticosteroids, which can be either oral or IV, based on what school of thought you follow. You get a good response and then you taper it. If the patient is poorly tolerating steroids, unable to continue for a long time, you may consider local depot, or you can consider radiation, which we'll come to later. But if you don't get a good response or a poor response or despite adequate dosage, is when you think of biopsy and then try to get a specific cause for it and accordingly treat it. So, few pointers to keep in mind. Before, if you're suspecting orbital inflammatory disease, make sure that your patient is off steroids for at least 2 weeks, because steroids can downstage or reduce the amount of inflammation that you see. More importantly, lymphoma also responds to steroids initially, and if you give steroids, then you may miss out on a diagnosis of lymphoma. Always ask your pathologist to perform an IgG4 staining in patients whom you have biopsied for orbital inflammation and get IgG4 systemic serum levels. It is now routinely done across all large referral laboratories. And if you do get an IgG4 positive level or staining, ask the patient to get a rheumatologist consult. Now you've suspected our IgG4, you've got a positive stain, and you've diagnosed the patient as IgG4 related orbital disease. Now what? You continue with your first line of treatment, which is systemic steroids. relapses are relatively uncommon, and you have to follow up the patient periodically. Interestingly here, serum IgG4 levels can predict the rate of the relapses, and if the serum IgG4 levels don't fall after initial treatment, that indicates that the patient is more likely to have a relapse later on. So the next question, if you're going to give steroids, then why are you telling me that they are different from NSOID? Because it is the same thing, and that is a point that we'll come to later on. Now, if there is a relapse with oral steroids, you must think of rituximab. Now, there is enough evidence that rituximab is even being suggested as the first line of treatment for IgG4 related orbital disease. Additionally, radiation is also being recommended as a first line of disease in cases of IgG4, or can be used as a reserve in recalcitrant cases of orbital inflammatory disease, especially IgG4. We had a patient who was a 26-year-old girl, presented with orbital inflammation. You can see this was classical myositis involving the extraocular muscles. We treated her with steroids. She gave a good response. Again, she came back with repeated episodes of inflammation. You would treat her with steroids, it would reduce, but she kept coming back over and over again. She had finished or exhausted her dosage of steroids. She was put on azathioprine. She responded. However, she was married and wanted to conceive, so we had to take her off azathioprine. And prior to doing that, we gave radiation, low dose radiation through the orbit. She was IgG4 positive, and after radiation, she is absolutely disease free with no proptosis and complete resolution of the disease. So radiation can be a good line of treatment when you've exhausted everything else. And the reason this is IgG4 is not the same as NSOID is because systemic involvement is seen in 68% of the patients. And when you say systemic involvement, it is inflammation and enlargement of the salivary gland in 43%, lymph nodes in 27%, and pancreas in 20%. Therefore, a rheumatologist consult and systemic assessment is very important in IgG4 related disease. Most importantly, patients with IgG4 related disease have a higher incidence of lymphoma, and therefore pathologists should be aware, as they say, of the potential of lymphoma to develop in patients with IgG4 related disease. More so if you've treated IgG4 related disease and the patient then comes to you with lymphadenopathy, you must have a high degree of suspicion that this could be lymphoma. So clinically, is there a difference? If a patient comes to you, how do you figure out, or how do you have a hint that this could be IgG4 or this could be regular NSOID? IgG4 is usually chronic, not acute or subacute. IgG4 has less intensity of symptoms, which means there will be lesser pain, lesser diplopia, lesser congestion, lesser chemosis, lesser proptosis. Usually 68% of IgG4 related orbital disease is bilateral involvement, and the bilateral is almost always lacrimal gland rather than extraocular muscles. So are we justified in doing a biopsy for every patient of suspected orbital inflammation without treating with steroids? We don't know yet. So this was a study where we collaborated with Guy Ben Simon. We retrospectively reviewed 100 consecutive biopsies that were previously done when IgG4 was not available, and stained all those sections with IgG4 to see if staining with IgG4 changes any of our previous diagnosis. And you'd be surprised, 17% of the patients who were found to now fit the diagnosis of IgG4 disease, which means we missed the diagnosis of IgG4 in 17% of the patients who were earlier treated. And they were treated as thyroid eye disease, orbital inflammatory disease, benign reactive lymphoid hyperplasia, and even lymphoma. So every patient of the orbit where you are doing a biopsy for lymphoma, for orbital inflammatory disease, has to be stained for IgG4, because it's a distinct entity and has systemic ramifications like the possibility of developing lymphoma. Keep a close follow-up and look for red flags like systemic involvement, lymph nodes, parotid gland, other salivary gland enlargement. Have a very low threshold for biopsy in patients that don't fit your the typical symptoms of orbital inflammatory disease. Remember, lymphoma is a real possibility. Up to 20% of all IgG4 patients during the natural course of the disease will develop a lymphoma, which is why having a rheumatologist on board to help treat these patients is extremely important. Thank you so much. So if there are any, I have another session concurrently going on. So if there are any questions, I can take that now. Right. So for IgG4, it is recommended that after steroids, you directly use rituximab rather than steroid sparing and immune suppressants. If rituximab doesn't work, then you can use azathioprine as your first line of treatment then. That's what literature says. I have actually not had to fall back even on rituximab. Steroids usually gives a good response to these patients. And also rituximab in India is a little expensive. So,
Dr. Arjani, please come as Akshay Nair is leaving the session. One photograph, then we will start the next session. Thank you, Dr. Akshay, for nice presentation on the IgG-related 4 orbital disease and lymphoma. Now I invite our next speaker, Dr. Kasturi Bhattacharya ma'am. Dr. Kasturi ma'am need no introduction. She is the only ophthalmologist in Northeast India who is having double FRCS, FRCS Edinburgh, FRCS Glasgow. Madam is presently working as a director, clinics and academics at the Sri Sankaradev Netralaya, Guwahati. She is a recipient of several awards, more than 48 international national awards, including 2 new awards day back. And ma'am is a regular examiner of the FRCS for last 17 years. And she is also recipient of Asia Pacific Achievement Award and chief instructor in American Academy of Ophthalmology. Now I invite Dr. Kasturi ma'am to talk on newer advancement in the thyroid eye disease.
To all of you, and thank you, Dr. Maurya, for having me in your session. It's a great honor for me, and always wonderful to learn so much from each other. So my topic is something I was thinking that I should start this session because it's too much of immunology, and I don't know whether you'll enjoy it or not. But let me start by mentioning that there's so much of new treatment modalities that have come in the thyroid eye disease. And when we say that this TED, this is a very complex disease which have a very long clinical course and ends up with a sight-threatening and debilitating ocular sequelae. So though there were limited therapeutic options available, however, in the last decade, there has been a deeper understanding on the underlying pathology that helped navigate the new treatment option. So these treatment options are based on CAS, that is the clinical activity score, the severity and the duration of TED, as all anti-inflammatory and the immunosuppressive are not very effective after 18 months of the disease. So we should be very careful while starting this disease. And by definition, it is classified as either active or inactive, or mild, moderate, severe, or sight-threatening. And this is a classification given by UGOGO, which is the best classification, where it is all based on the clinical activity. There are 7 attributes to it, and if you have, and each attribute is given 1 point. If you have a CAS of more than 3 out of 7, it is known as an active disease. However, if you want to know the progression, they have added another 3 attributes, which are 8, 9, and 10. So if you have a CAS of more than 4 out of 10, this is known as a progressive disease. And definitely in the new UGOGO classification, they're taking into consideration the quality of life. However, the American Thyroid Association has different classification and which they classify as class 0 to class 6. So what are the treatment options? One is a medical therapy, one is a ORT, that is a orbital radiation, one is a functional surgery, and next is the cosmetic surgery. All medical therapies are the targeted therapies, basically the biologicals, and the surgeries are minimally invasive surgery, which we do for thyroid eye disease. I'll be showing you some of the surgeries. And the cosmetic surgery are basically image guided to address the aesthetic component. So, a patient focused comprehensive plan based on the clinical components of the disease and the quality of life and psychological well being are taken into consideration in the novel effective targeted therapies. So, let me tell you briefly what are these targeted therapies. One is very simple, they modify the disease in the initial stage. So, these are all aimed to prevent the fibrotic sequelae of the thyroid eye disease. And the second is surgery, which is minimally invasive. It is basically aimed to take care of the aesthetic component and the rehabilitation. Oh. So the treatment option can be either medical treatment. It's very nice. The first time you're doing it's nice when we are in a closed group. No? Medical treatment, it can be a radiotherapy, it can be a surgery or the cosmetic. And all these are basically aimed to modify the disease in the early stage. So when we call the medical treatment, it is basically the targeted treatment, or it can be number two, the surgeries are basically the minimally invasive surgery, and the cosmetic surgery is basically the image assisted, which is to address the early aesthetic component. So we need to have patient focused comprehensive plan, and which is basically to manage the chronic component of the disease and also the individual quality of life. So if we go to the novel effective therapies, we will see that these targeted biological therapies are basically they have come out to modify the disease in the very early stage, because it is being this has been come out only to modify the disease in the very early stage, because what happens, the earlier we treat it, the chance of fibrotic component are less. And secondly, the most important thing that when we do the surgery, when we started the surgery, we used to do a very major surgery. We used to remove the whole of the lateral wall or the medial wall, inferior wall. But now there's a very interesting concept by many of the American doctors. They say the pathology is in the fat, the pathology is in the muscle. So why do we need to cut the bone? Still, that concept, people are working on it. Do we really need to work something on the fat? And for that only the new treatment, the immunologicals have come out. And still we are also doing a combination of both the fat and the bone removal. So when we talk to the pathogenesis, this is something very interesting, because this understanding of the pathogenesis had really made a paradigm shift in the management of the thyroid eye disease. And when you see the pathogenesis, basically are three pathogenesis. You should know the role of CD34 positive and the CD34 negative fibrocytes. Okay, that is number one. Number two is the insulin growth factor 1 receptor mechanism, and number three, the T cell pathway. So all these three plays an important role. And when I talk about the CD34 positive, you always remember there is something called positive, there is something negative. So positive are dangerous because it leads the conversion of these fibrocytes to a myofibroblast or to a excessive proliferation of the lipocytes and leading to the enhancement of the gags. But if it is negative, the negative leads to slit tube. What it does actually, if you see very basically the thyroid eye disease, what happens, there is the THSR, there is an stimulation of the THSR. So all this ultimately works on the THSR, and this leads to the, when the THSR is being stimulated, the TNF, the tumor necrosis factor alpha, is being stimulated, and that is the main thing responsible for the inflammation. All the inflammation, sorry, I'm saying that all the inflammation that you see in the muscle is basically due to the TNF alpha. So all these things are ultimately targeted to decrease two things. One is the cytokines, which are released by the T cells, basically the T helper cells, and other one is to target the TNF alpha. So just remember, for the residents, I'm telling you, if it is CD34 positive fibrocytes are dominant, it is going for severe thyroid eye disease. If it is CD34 negative dominance, then it is go for mild or no thyroid eye disease. So now lots of time, treatment has come out to target the CD34. Then the second important concept is the insulin-like growth factor. What it does, it inhibits the THSR. So the THSR ultimately what it releases? It releases the cytokines. So it inhibits all the cytokine release, and the cytokine is the main factor responsible for the all the tissue reactivity. इससे हो जाएगा, ये हमारा है. I'll keep on continuing. So then we have the T cell subset. So T cell subset, if you look, this is a very new concept, which is basically the T helper 1 and the T helper 2. So T helper 1 you find in the chronic disease, T helper 2 you find in the active disease. So if you can suppress this T helper 1 and 2, the 1 in the active and 2 in the chronic disease, and this plays a very important role. And today this is, if you attend the ARVO meeting, you will say this is the most hot topic. It's a hot topic for research where they are all working. Oh, it's coming, no? So where they are all working on this T helper cells. So these are the three. So you'll know, one is the CD34 positive negative fibrocytes, one is the insulin growth factor, and also one is the T helper cells. So what is the recent guidelines? And this is the most recent, which has really changed our approach to the thyroid eye disease. So they say that if you have a mild and active or recent onset, then what is the treatment? You control the risk factor, the most important being smoking. Go for the local treatment, that is treat the cornea, and third is supplement with selenium. And this they found that improves the eye manifestation, they improves the quality of life, they prevents the progression of the disease. And they have also mentioned, now it is validated, you can use the botulinum toxin. All these days it was not validated to use for your eyelid retraction. So they have also mentioned that if you have an eyelid retraction, you can use a botulinum toxin. And you can also use the artificial tears, the gels and the fluid for the corneal problem. But if you have a moderate to severe and active disease, the first line of treatment, all these years we were only giving IVMP. Now they say IVMP with mycophenolate. And how much IVMP you are giving? 4.5 gram cumulative dose, and mycophenolate, which is giving 0.72. In fact, all my patient who comes to me, I start with both. And I find that it's a much better while only giving steroid alone. But if you find that the diplopia is progressing, loss of inflammatory changes, the exophthalmos is progressing, then you go for alternate first line of treatment, which is a high dose of IVMP. Initially, we used to say in the 2018 UGOGO used to say it should be either in the 0.5 step or you give 1 gram. But now they are saying 0.75 gram per day, per week for 6 weeks, with the highest cumulative dose of 8 gram per cycle. But if you feel that still it is not working, then you go for the second line of treatment. And you remember all this, because I will again come back to you. The second line of treatment is IVMP 0.75 gram with a maximum cumulative dose of 8 gram. Second comes steroids with the cyclosporine. Third comes the radiotherapy with steroid. Then comes the teprotumumab, the rituximab, tocilizumab. So even for the moderate to severe and active thyroid eye disease, they are saying that it is only teprotumumab, rituximab, tocilizumab, the radiation, they are coming as a second line of treatment. Can you understand? The first line is again IVMP. So consider, and if they are resistant to glucocorticoids, then also you can give for the systemic, or also you can go for local. So initially when we were giving 24 milligram of peribulbar steroid, people were questioning us, why you are giving, especially the glaucoma people, they'll be at the back of us, you are giving steroids, you are giving, increasing the IOP. But now it is being validated by UGOGO. If the patient is not tolerant to a systemic steroid, go for a local steroid. And as of now, I don't know the dose, but what I have seen from my teaching from my doctors from abroad, all are going for 24 gram. But there are some European doctors, they are also giving 40 milligram. Okay. So if you have a very side treating, how much? This is a time where you can go for 1 gram. But how you go 1 gram? On the alternate day. Can you see? And if still you don't have no response, then only you go for thyroid decompression and along with it. So you can have a thyroid decompression as a first line of treatment, even if when there is site threatening leading to this thyroid optic neuropathy. So what is the role of radiotherapy? First, it inhibits, it acts on the lymphocyte apoptosis. Secondly, it decreases the inflammation by acting on the terminal differentiation of the orbital fibrocyte. So are there any role? Because initially in the active stage, not responding, we used to go for radiotherapy. Now what the level 1 evidence shows, that only ORT will not improve the proptosis or any soft tissue changes. It should be a combination of ORT and steroids, and this will drop the ophthalmological index, and also the patient with early and progressive moderate to severe thyroid eye disease have the highest response. But again remember, IC211 says that effective second line of treatment for moderate to severe. So the radiotherapy is a second line of treatment as per the IC211, and it should be steroid plus your ORT. There are other immunosuppressive, I'll not go much into details. So what is the role of this mycophenolate? It acts to inhibit the proliferation of T and B lymphocytes and suppresses the antibody production. And this is a very good paper. I think all of you should read what is the Mingo study. Based on this Mingo study, which was published in Lancet, they have come to the role of the mycophenolate mofetil. So I think all the residents, please go for it, because Mingo study, what it shows, that if you have the mycophenolate along with the IVMP, or they have made a study with the steroids, they found that this combination of steroids and mycophenolate leads to superior improvement of the ophthalmic index in terms of eyelid swelling, CAS, the lid changes, the diplopia changes, and the motility. So briefly about the biologicals, when we say, I'll make it very simple for you. It targets the immune cell and the receptors. What is the receptor? THSR. That is the main receptor. Even the insulin 1 growth factor receptor ultimately targets the THSR. It is a safer with greater efficacy. So rituximab, we have been using it for so many years. This rituximab ultimately works in CD20. There are others, I'll be coming to you later. But there is very important two trials. One is the Italian trial, one is a US trial. And you see the difference. And both this trial, they have worked on the rituximab. The Italian trial says that the rituximab is superior versus to steroid, whereas the US RCT says there is no difference. But if you look again to the Italian trial, they have involved the younger people. They have involved more smokers. So these are the people who have higher CAS score. And they have involved a less number of patients with prior radioiodine therapy. So that means the Italian trial is a much stronger trial, because they are taking the patient with a higher CAS score, and also they are proving that rituximab does have a role in the thyroid eye disease. And then, but you should always remember, the rituximab also has lots of complication in the form of the reactions, myalgias, etc., etc. So the question again comes, if you have a DON, this thyroid optic neuropathy, will you go for rituximab? What the IC211 study says, the IC211 says that as long as you don't have a DON, rituximab should be given. So this is the recent concept with the IC211. So this, the whole treatment you should know very well. And we have been talking about tocilizumab. This is basically inhibits the cytokines, the interleukin 6, and we all know the interleukin 6 basically acts on the adipocytes. So what are the studies are showing? There are some research, there are some manuscripts which are being saying, but I still feel what the latest research has said, that this tocilizumab is not significantly effective at 40 weeks. That means long term it is not effective, and there are higher recurrence rate, and we need a larger RCT. So we need a larger RCT to know whether this tocilizumab is actually working in a long duration. And this is not what I am telling. IC211 says that this is also a second line of treatment. This is not a first line of treatment. Then other things have come out like that, which I said TNF alpha. This is one of the main factors responsible for other inflammatory changes. So we have anti-TNF alpha, which basically targets this TNF alpha and decreases the inflammation. But till now there are no RCT, so we cannot say whether it is really effective or not. But there are some case report, there are some retrospective evidence. Let us go to the main one, the teprotumumab. This is very promising. And just remember, this is a FDA approved. So what I mean to say that this is basically where it is acting. This is acting on the insulin growth factor 1 receptor. It is given 8 infusion. I will not go into the doses. What I want to share, see the level of evidence. Phase 2 and phase 3 trial says it is active, moderate to severe thyroid eye disease, you can use it. That is phase 2 and phase 3 trial. Chronic, it is effective in chronic thyroid eye disease, which is being shown by the case reports and the publications. And also it is effective in compressive optic neuropathy, which is shown by the case report and the publication. So rituximab is not effective for the dawn, but they proved that teprotumumab is effective for dawn, number 1. Not only then, from UCLA, our very good friend Shoaib, he has also published that not only on these changes, it also works on facial and eyelid changes. Because of paucity of time, I'm not showing you. I have some patient where you will see thyroid eye disease with big fat out here. So this is also working on the facial and other eyelid changes. So I'll just briefly say in the phase 2 trial of the teprotumumab, what they got, the proptosis has decreased, the CAS score has improved, and the quality of life is improved. But what does phase 3 says? Also the diplopia has decreased. So this is very important, how the role of the teprotumumab comes. Now let me come to something more interesting, because I like to talk more about surgery than all the other day. So now we go for minimally invasive surgery, and one of the best way of minimally invasive surgery is when you can do just remove the bone and the fat in a very balanced and a controlled way. So this is what you can see, what we always say, the balanced decompression. You remove the lateral wall. This is the lacrimal keyhole I'm making, and go to the base, to almost to the superior orbital fissure, till you see the blue color. That is almost, that means can you see the blue color coming in? That means almost you're seeing the dura. So then also you make an incision and take out the fat. So this is what we call, you go medial and lateral. But what is this minimally invasive? We know the pathology lies in the fat, right? Now you have the control ultrasonic suction aspirator, and look and see. I'm just putting the aspirator and look at the tubings, how the fat will be coming out. Just have a look at the tubing. You did not need the cut, or what we used to initially, we used to cut with the scissor, and we put the suction, it keeps on suctioning. But now you already have some machines which are coming up, which we call it CUSA, and look at the tubings, how beautifully the fat are being taken, and you get a very effective correction. Very minimally invasive. The chance of injuring the nerve, because it will never injure the nerve, the chance of injuring the nerve or anything like this, or chance of excessive bleeding, because this fat are very resistant fat, is really inflamed fat. These are not very easy surgery. It almost takes 2.5 hours to do one surgery, and almost 4 hours to do bilateral. So these are the results I'll just be showing. This is another case you can see. This is only a fat decompression that I am doing. I'm just showing you how we put the CUSA. And you do once, first the lateral done, then the medial is being done, and then once you put the CUSA, and you'll see how controlled the fat is being aspirated, and you'll see the fat keeps coming on the suction tube. So these are some advances, and when I say any advance in oculoplasty, the technology and the technique goes together. You need the help of the technology if you really want to do a very effective surgery. And this is the same patient after a few days or few months following the procedure. This is after 2 years, the last picture that has been taken, and there's no recurrence at all. See this lady. Now what the UGOGO says, it says that if you have a very sight threatening, you have to go for decompression. I gave a steroid, I gave her even the immunohistochemistry, nothing worked. I have done a full lid blepharoplasty, and this is, you can see how the lid, now I have done a full blepharotomy because of the lid cicatrization, and you can see how beautiful the cornea looks. At least we could salvage the eye and the vision of this patient. This is pre, and this is the post-operative 10 days. So these are some of the patients that you can see. These are really challenging cases. Now what is the role of statin? Because I see that many people keep on talking about statin. Statin also, it has been found that it has some role, but when this study came out, when it was published in Lancet, they were taking those patients who already had a high cholesterol or the LDL level being high. So what I feel that most studies are required to take up those patients where we take a normal patient who does not have a high cholesterol. Then only we'll know the actual role of the statin. And now there are more newer treatment that the IMVT, people are talking because it is in the phase 2 trial. This is also a very good effective treatment for the thyroid eye disease. And before I end, I would like to mention some of the other therapies like the THSR antagonist, the Antec-G. There are very nice reports on Antec-G and also the immunomodulators. With this, I conclude. Thank you very much for your patient hearing.
Thank you, Dr. Kasturi ma'am, for a nice video-based and advancement in the thyroid eye disease. Sorry for interruption because of technical issue. Now, I will invite our next speaker, Dr. Tarjani V. Dave, is an oculoplastic surgeon. Now, she is a Associate Director of LB Prasad Eye Hospital, Hyderabad. She is passionate about the socket and orbital reconstruction. She had several innovations to her credit, such as management of migrator of orbit implant, use of expander for the congenital anophthalmia, and a body of work on sclerotherapy for lymphatic malformation. Now, Dr. Tarjani will deliver a talk, very interesting talk on the orbital reconstruction.
Thank you very much, Dr. Maurya, for having me on your course. I hope I'm audible. Excuse me, okay, yeah, all right. So, good afternoon, everyone, once again. So, I'm Tarjani. I work at LV Prasad Eye Institute, Hyderabad. I'm going to take you through what is new in orbital reconstruction. I have no financial disclosures to make, and you'll be seeing, excuse me, this is not playing correctly. All the images have gone off. The screen has also gone off. Why is this? No, all the images have gone off. No, I have it on the system only.
Can you try to close it and open it again?
No, it'll take a whole long. Made it on PowerPoint only. Yeah, finally, I'm happy something is coming up. All right. So I have no financial disclosures to make, and you'll see certain full face photographs of my patients for which we have the consents in place. Considering the number of images, you would have imagined the plight of my myocardial fibers when I saw no images were playing anyways. So I'm going to talk to you on a few basic aspects in orbital fractures. And then, the few advances that we have. The points along which I'm going to talk to you are listed on your right hand side, and these 10 points I hope to cover for you in this brief period. Now remember that this is all a perspective. What might appeal to my mind might not be something that appeals to everybody's mind, but I'm showing you my prism of looking at orbital fractures and what is new in the management of orbital fractures. You're always free to have a contrary opinion, but I'm just putting across things that appeal to me. So as we all know, the role of the orbits is to protect the eyeball, right? That's the prime role of the bony structure around the eyes. And there are all these facial buttress systems around the eyes which have a large part to play in the protection of the eyeball and the soft tissue of the orbit. When we look at fractures that we tend to see as an ophthalmologist, then these could be simple fractures of the floor, or they could be larger fractures. We, in our practice, see zygomatic maxillary complex fractures as a number one fracture in our setup, probably due to the proximity to the highways and the large number of road traffic accidents that we see. The second one is the naso-orbito-ethmoid fractures, which are classified into multiple types and are primarily along the medial wall of the orbit and have some involvement of the skull base. The third fracture that frequently comes to oculoplasty surgeons is your pure floor fracture, which can either be a blowout fracture. You're seeing over here the bone of the orbit is actually into the maxillary sinus. So that's a blowout where the contents are prolapsing into the maxillary sinus. You can also paradoxically have something known as blow in. So what is happening here is the bone is actually towards the orbit. And these are the patients who will actually present with proptosis, right? Very intuitive. When the bone is coming towards the orbit, the volume of the orbit is reducing, and hence you tend to see proptosis, the exact opposite of what you do in thyroid eye disease when you're decompressing the orbit. So these are certain fractures that you're likely to see in your practice. Now, one word of caution is with these web-offs or the white-eyed blowout fractures. What are these fractures? These are fractures which you typically tend to see in younger patients because the bone is very chewy and is very, very sort of springy. So what happens in web-offs is clinically you have no symptoms that this child has a fracture. The eye is white completely. There's no sign of any trauma except for the history. And what happens radiologically is, or what happens as a sequence of events is, the floor fracture component happens, the contents go into the maxillary sinus, especially the inferior rectus muscle, and before the contents can come back into the orbit, the bone snaps back. So what is happening? Your inferior rectus, which on the normal side is inside the orbit, on the affected side is actually in the maxillary sinus. That muscle has got trapped into the sinus and the bone has come back in position. So you don't see any fracture as such. The orbit is continuous, but then your inferior rectus is entrapped in the maxillary sinus, and this produces a vasovagal effect. So you'll have parents of these children sort of come to you saying, giving you symptoms like, you know, he's having these episodes of fainting, he's sort of, having dizziness, he's passing out of consciousness on and off. And if you see these patients closely, you might see some amount of bradycardia telling you that, okay, this child is having a vasovagal. And this is the only condition that requires emergency treatment, admission, putting the child on pressors, and operating as soon as possible. Certain other situations are large panfacial fractures that you are likely to see if you are in an institutional setup or if you have a collaboration with maxillofacial surgeons, where again the role of an oculoplasty surgeon becomes very important. So when you are looking at surgical planning of fractures, it's only these web-offs, the white-eyed blowout ones, that have to be repaired immediately, because you don't want the child to have an untoward effect because of the vasovagal that they are developing. The other fractures, you can, based on your convenience, based on your availability of implants, you can take somewhere, around 2 to 4 weeks to plan these fractures for surgical correction. So remember, the most important part is web-offs require immediate surgical correction. All other fractures can be planned based on how the eye is, the edema is, and whatever implant you're planning, whether that is available to you or not. The other concept I wanted to talk about is this concept of hidden incisions. So you saw Dr. Kasturi also show you beautiful outcomes post-decompression. How do we manage that? So we take the incisions in the eyelid in such a way that for accessing the upper and the lateral part of the orbit, imagine the orbit to have 4 quadrants, okay? So the upper and the lateral part can actually be accessed through the eyelid crease, the pink band that you're seeing over here, which will allow you to hide the incision in the eyelid fold, but yet go in and access the superior and the lateral orbit. Now the same thing for the inferior and the lateral as well as the medial orbit can be done by a transconjunctival incision in the lower eyelid. So you've eliminated cutaneous scars altogether. And for certain specific indications, like you want to go to the deep medial wall for whatever reason it may be, you can use a transcaruncular incision. So these are all schematics which I drew as a fellow, which still stay with me, where you can use these incisions to completely avoid any sort of skin scars in orbital surgery. Briefly, a word about image-guided surgery. So what exactly is image-guided? All of us have been using GPS to travel across, one corner to the other of Bombay, right? So it tells you where exactly you are geographically. Similarly, image-guided surgery is a piece of equipment which tells you where exactly you are in the orbit while you're operating, and it uses the bony orbital landmark. It works very similar to the GPS system that you have on your phones. So I'm just going to show you one quick video of fracture repair. So this is a lady from Bombay whom we treated. She has a left orbital floor fracture, and You can see that this is the area where the volume has expanded. That's her fracture on the left side. She's bothered about the enophthalmos, and we are correcting her fracture for a cosmetic concern. So you can see that there's limitation in superior movement of the eyeball on the affected side. And this is the navigation machine where we are actually doing the virtual planning of how big the defect is and how should we contour our plate by mirroring the unaffected orbit on the affected side, so that we can actually bring back the same amount of orbital volume and help her have a good aesthetic outcome. For the want of time, I'm going to skip a few parts of the video. Approaching the orbit is very standard via the inferior conjunctival incision. This is the plate which is being placed inside, and that's the navigation probe which is being used to figure out where exactly in the orbit that plate is now resting. So, and this is shown to you on the CT scan on the monitor of the machine, so that you can understand whether you've given a good correction or not. So I'll just take a few more seconds to explain that to you via radiograph. So what have we done over here? This is the normal side, this is the affected side. You see the red lines, that's the mirroring of the right side onto the left affected orbit. And you see that blue probe over there. The probe is resting on the plate, and it is telling us that the orbital plate now is at that red line that you have made. So you've got a good correction or you've got a good plate positioning intraoperatively. That confirmation is what you can get by using navigation. And for patients who come to you for aesthetic concerns, this becomes a very big plus in your armamentarium. Couple of other things briefly that I wanted to talk about. One is 3D printing in the treatment of fractures. Now this allows you to do a whole lot of virtual planning on how you want to go ahead treating your fractures. You can actually print life-size models of patients' orbits, and then actually do your fracture repair on that model and then replicate it on the patient. Or you can even craft implants based on the shape of the broken orbit and the reconstruction that you want to impart. So if you are technologically savvy, you can use free online softwares yourself, like we've done over here, to crop the patient's 2D CT scans into 3D models and then print those 3D models. Or you can just outsource it to companies who easily tend to do it for you and give it to you. However, there's a cost attached to it. So this video here is showing you all the gimmicks that we have done to print the patient's orbit in-house. And this is that orbit model. It comes along with this support material, which when put in a water bath completely dissolves and gives you the exact life-size orbital model of the patient, onto which you go ahead and craft whatever you want to do. Alternatively, you can have this outsourced, as I mentioned to you. This is one of my patients, post-mucormycosis, osteomyelitis of the bone, treated with debridement, and now has a deformity which we wanted to repair via a patient-specific implant. And what we've done over here is we've crafted an implant which gives back the whole lateral rim, the floor, the maxillary buttress which was damaged, and as well as some part of the floor of the orbit going inside over here, as you can see. So these kind of gimmicks and advances are available to us for treating patients with complex orbital diseases. This is one more, plexiform neurofibromatosis, where there's brain prolapsing into the orbit, which I want to block at this posterior part, that I've done with the help of Medicaid to craft this specific implant for the patient. And additionally, there is an asymmetry between the two orbital rims. If you see the right side orbital rim, the floor and the lateral wall are much more expanded, which you see in patients with neurofibromatosis. So I've crafted one more implant to fit on the lateral wall and the floor, and these two implants then go to the printer and finally come to you. So your job is only to open up the orbit, place these there and just screw them, and you really don't have to do any other surgical maneuvering inside the orbit. One last case that I want to show is about this gentleman who has an anophthalmic socket with a large frontal bone defect and a roof defect. You can see that there's no roof at all. So if I want to place an implant over there, I'm worried that it's going to go and sit in the brain after a point of time. And hence the treatment of this skull as well as the roof becomes very, very important, for which again we've used the help of patient-specific implants to craft an implant that not only covers the frontal part, but also covers the roof. So I don't have the clinical picture of this patient right now, but if you examine him, you can see the cranial pulsations right under the frontal bone, because there's no bone actually over there. So these are the sort of things that you can do and you have in your armamentarium. Because Dr. Grover is already here and we had so much technological issue, I'm going to skip at this point of time, but thank you so very much for a patient listening. I hope to pass on to Dr. Grover for at least a few minutes for his talk. Thank you very much.
Thank you, Dr. Tajini, for a nice elaboration on the orbital reconstruction. Now I invite
this now, because I'm using a lot more of MMCR, Mueller's muscle conjunctival resection, and minimally invasive levator aponeurosis surgery. So phenylephrine test is critical. Those which show a positive response to phenylephrine 2.5% over the next 5 minutes are the best subjects for Mueller's muscle conjunctival resection. The advantage is it is very predictable, very simple, anybody can do it, and takes a few minutes, and you get very predictable results with dynamic lid movements and natural crease, and no disruption of anterior structures. So let's look at the video simply. We are just marking the upper border of the tarsus, and then you just mark about 4 millimeters away, and you pick up this area, which will then excise 8 millimeter of the conjunctiva along with Mueller's, and you use a Putterman's clamp, which is important. So this clamp is important for this surgery. Once you've held this tissue and held it symmetrically, you can then pass your sutures. We use 80 vicryl suture for this purpose, but of late we have also been using 60 nylon with the ends exteriorized, so that it becomes even more simple. And then you pass sutures like a mattress suture, one side to the other side, coming back to the same side. Once you've gone across with these sutures, then the procedure is almost done, because you will excise double this length, 8 millimeter of conjunctiva along with Mueller's. If you have a little higher amount of ptosis, sometimes you can increase it to 10. If the ptosis is very minimal, sometimes you would reduce it to 6, as you will see in some of these examples that then it gives very predictable results. There is no contour problem. There is no problem of overcorrection. The major problem with aponeurotic ptosis otherwise was overcorrection. The second procedure that I'll show you the video of, which has given us very predictable results, is the use of small incision. The small incision aponeurotic repair, where again you are working through only a 1 centimeter incision. So that has again given us a big advantage of a good contour. So once the suture is passed, the important thing is to cut very close with the feel of the metal along this, so that you don't cut the suture. So if you've used an 80 vicryl, you make sure you either exteriorize the threads or you place the knots, bury the knots, so that you don't cause an irritation. And that completes the procedure. So we are using a buried knot, but more often now I use a 6 nylon suture and exteriorize it. So that works well. So the advantage is the predictability of the procedure. You can see the ptosis here, which has been corrected well, and the contour is maintained very well. There is never any problem of overcorrection. So if you have a positive phenylephrine test, this is giving excellent results. Even for milder cases like this, where we would have been afraid 1 millimeter or something, we are now able to do it by doing just 6 millimeters. Or for sometimes for a little more severe ones also, provided phenylephrine test is positive. You can see how the tarsal platform show decreases beautifully. So the conventional aponeurotic repair requires a very good judgment and on-the-table assessment. So this was how we were conventionally doing it in these cases, where we exposed the orbital septum, opened up the orbital septum, dissected on the surface of the tarsus, and opened up the aponeurosis after opening up the preseptal pad of fat. And then you could carry out, after dissecting it from the undersurface again, we reattached the aponeurosis to the tarsal plate based on the intraoperative judgment. Generally, very little if any, resection is done. You only need to just reattach the on the surface of tarsus with 3 sutures, with the part which is proximal at times even to the white aponeurosis, if the levator action is good. So this has to be very conservative. Only in cases where levator action has decreased, you may need to do some resection. But so this gave good results, provided you had good on-the-table judgment, you could get results like this. But now this small incision one, we are just giving a 1 centimeter incision, as you can see here. And we are not doing any further dissection, not opening up the orbital septum, not exposing the preaponeurotic pad of fat, not doing too much dissection on this, just a little dissection on the surface of the tarsus. And then you simply pass the suture through the tarsus and through the part that you think is appropriate based on your levator action. You would pass this single suture and tighten it, assess, and then put a final suture and then close the skin. And this, let's briefly look at that part of the video. So you've given a bite in the tarsal plate without having done any dissection under the levator or on the surface of the levator, and we're just passing it through the stump of the levator, which we have dissected from the surface of tarsus. So this makes the procedure much simpler, and when you tighten this, you can assess the correction, and this is all that you need to do. So it has now been realized that these minimally invasive procedures work very well. So instead of all that dissection that we did there, this is all that we will need. So you can get, even on day 1, there is very little edema or reaction. As you can see, this is all day 1. And by the end of 15 days, these eyes behave very well. Contours are good. And the comparative study that we did of 18 patients in each group, using that contour thing, showed that the contour is better in this method. In fact, you don't need, in acquired cases with very good levator action, to take all those steps of three sutures and dissection. So thank you very much. This is the one major change that I have made in my practice.
Thank you, sir, for nice video-based teaching about the ptosis and newer advancements in ptosis surgery. Thank you, sir.
Before we end, I think you should know about Dr. R Maurya. He is doing amazing work. I'll just let you know briefly. He is the one who had done a PhD, recipient of multiple works, and he has done great innovative work in ocular oncology. And he is a great teacher. I get so good feedbacks from his students. One of his students is also doing a fellowship under me. And I think he's a brilliant person, and he's a chief editor-in-chief of 2 journals, International Journal of Ocular Oncology and International Journal of Clinical Ophthalmology. So it's a real pleasure I have seen him growing from oculoplasty surgeon to a great international surgeon with international rapport. So very nice. Congratulations, Dr. Maurya. And I should also congratulate your students also very good. I'm very happy with Dr. Deepak. He's with me. And he says so good words about him. So thank you, Grover sir. Thank you, Tarjini. And Akshay is not here. And thank you everyone for being with us today on the last day